Welcome from sunny San Diego at the 83rd Annual ADA Diabetes Sessions. I'm Akshay Jain, an endocrinologist from Vancouver in Canada.
Hi, I'm Kevin Fernando. I'm a general practitioner with an interest in diabetes from Edinburgh, Scotland.
Kevin, how's the session going for you? What are the key highlights that you've seen so far?
Once again, it's been a fantastic congress to date. Very much, I think the theme has been cardiometabolic syndrome, the overlap of type 2 diabetes, metabolic disease such as obesity and NAFLD. So really one of the key sessions, of course, was the tirzepatide trial. I think the SURMOUNT-2 trial, which really cemented, didn't it, tirzepatide as a third generation, to use the presenter's words, obesity medication with significant weight loss benefits, of course, glycemic benefits, and also clinically meaningful improvements in a range of cardiometabolic risk factors, including liver enzymes, nonfasting HDL. So really a great therapeutic option for particularly our younger, higher risk cardiometabolic patients.
It's fascinating, isn't it? We know that people living with type 2 diabetes have a much harder time losing weight, probably because of agents like insulin or sulfonylurea that we use commonly. Part of that is the pathophysiology of diabetes. But having agents like tirzepatide in this consideration, there's so much more weight loss that we're seeing. And this probably paves the way for looking at cardiovascular outcomes down the line as well.
Absolutely. My understanding is in people living with type 2 diabetes, they produce inherently lower levels of GLP-1 as well compared to people without type 2 diabetes. So there's no doubt that's driving the reduced weight gain perhaps we see with some agents. But as you said, that's why it's so exciting seeing results like SURMOUNT-2. With the weight loss we saw in SURMOUNT-2 is similar or exceeds bariatric surgery, doesn't it, in many respects. And as you said, a key part will be the upcoming cardio, renal and hepatic outcome data, which really will allow us to bespoke use of these agents, I think, according, yes, to the presence of type 2 diabetes and obesity, but also specific comorbidities, particularly things like NAFLD, which really is another epidemic we're facing over the next few years.
Oh, very well said. Highlight at this ADA has been the focus on non-alcoholic fatty liver disease. We saw agents like survodutide, another incretin therapy, where we're now seeing that there can be significant degree of weight loss, including in people without diabetes. And this agent has been developed for the management of NAFLD.
Absolutely. Tragically, in Europe, NAFLD is now the leading cause of liver transplantation. And in my own practice in Edinburgh, we've had, sadly, a first death from NAFLD cirrhosis in a young individual with type 2 diabetes. So we desperately need new therapies to help tackle NAFLD, alongside, of course, intensive lifestyle intervention.
Looking at all the incretin therapy that's been discussed at the sessions here, one really cool concept that I saw was the oral GLP-1 therapy, or for glipron. I know it took you and me a little while to memorize how to pronounce that. But from a primary care perspective, right, when you look at the data from orforglipron studies, what is the key highlight that spoke to you?
There's no doubt the data was compelling for orforglipron, but really the thing that struck me most, it was a non-peptide oral GLP-1, as opposed to oral semaglutide, which is, of course, a peptide-based GLP-1. And that, of course, has impacted compliance potentially with oral Rybelsus. Because it's peptide-based, it's rapidly degraded in the gut, of course, isn't it? And that's why it's important to take it at least 30 minutes before any other food, drink, or medication, no more than a sip of water. Otherwise, it does significantly reduce the bioavailability. So for me, a real highlight with orforglipron is the fact that it is non-peptide, so perhaps can be taken alongside other food, drink, medication, so might enhance concordance. Because importantly, whilst we have all these fantastic new therapeutic options, they really only work if our patients take them.
Very well said. One highlight for me from this session was the fact that we now have a amylin analog as well that you can combine with a GLP-1 therapy. So we saw data from the phase 2 CagriSema new molecule. And in people with type 2 diabetes, using this combination CagriSema, we were able to see unprecedented A1C reduction, more than 2%. Weight reduction was again very, very favorable, 15, 20, sometimes even more than 20% weight reduction. So I think the future looks very bright. Now it behooves us as clinicians to use more of the incretin therapy So we are all familiar with GLP-1. We now have GIP. There will be a glucagon receptor activity and then amylin as well. Do you think from a primary care perspective, we might be able to push back insulin a little bit more by using all the incretin therapy?
Absolutely. I really consider insulin as a last resort therapy now, with the compelling weight loss benefits, cardiorenal benefits of the injectable therapies. There really is no reason why we should be considering insulin earlier on in the treatment pathway. My main concern, to be honest, from a primary care point of view, most of my generalist colleagues in primary care are overwhelmed by diabetes. I mean, we're having a very excited conversation here about the different combination therapies. I've been away here in this Congress for 4 or 5 days now, haven't we? And my colleagues are messaging me with all these diabetes queries, because inevitably I've de-skilled them, haven't I? Because I take the lead in my practice for diabetes. I think that is the bigger challenge. We're facing an epidemic, particularly of younger people, with, as I said, with cardiometabolic disease. We need all our colleagues on board to initiate these therapies. I think a lot of education is going to be required, isn't it? Particularly for our generalist colleagues who perhaps don't have a specific interest in diabetes or cardiometabolic disease.
Absolutely. So new pharmacotherapy that is not only effective, but also safe. Speaking of that safety part, most important safety aspect that you and I are worried about is things like hypoglycemia.
Yeah.
And that's where new technology is very, very crucial. So one other highlight of the ADA was all the fascinating technology. I felt like I'm a kid in a toy store, looking at all these fancy devices. So CGMs, I know you guys use it a lot in the UK. We're using it a bit in Canada as well. What about CGM in type 2 diabetes? All the information that you saw here, how does that change your outlook?
Oh, absolutely. It's very exciting diabetes technology. It almost felt like an Apple developers conference at points, didn't it? This Congress, not a diabetes Congress. But there's no doubt, CGM in type 2 diabetes can be transformative for that person living with type 2 diabetes. Again, in the UK, from a primary care perspective, we're really just starting our journey with CGM and type 2 diabetes. NICE have opened the doors to the use of CGM in type 2 diabetes, but it's still fairly prescriptive. I'm going to be honest, I've already gone off-piste in terms of using CGM, because it's essentially an educational tool, isn't it? And I think has far-reaching uses for people living with type 2 diabetes. Like when we just had blood glucose testing strips. Again, we had strict criteria in the UK who to give blood glucose testing strips. But I was a big fan of giving it to anyone with type 2 diabetes, as long as they did something meaningful with those results. If they change what they eat or when they eat, or exercise, timing or duration, for example, of exercise, then that was a clinically meaningful intervention. So that's where I see CGM positioned. I saw that really interesting session about the use of CGM for people with pre-diabetes and people with obesity. Again, all around its role as an educational tool. Yes, these studies are small, pilot studies essentially, small numbers, but really exciting data that shows the potential of CGM in type 2 diabetes. And then on the other side of things, where I've been using CGM in type 2 diabetes in my own primary care population, is to de-escalate therapy. I'm sure you'll agree, as GPs, nurses, pharmacists, we're very good at starting drugs, not so good at stopping drugs, are we? So certainly in my more frail patients, or perhaps now in a nursing home setting on complex insulin therapies, the harms of intensive insulin therapy regimens far outweigh the benefits. So I've been using CGM to help de-escalate and simplify some of these insulin regimens. And they don't need long-term CGM, just a few weeks, maybe slightly longer, to help me simplify or sometimes even come off insulin. So I think the opportunities are really exciting in type 2 diabetes.
Very well said. So many benefits, right? I think you really put it very nicely where you said that you really need to make sure the education perspective is gathered.
Yeah.
In my mind, if I were to use a CGM just as a glucose monitoring device, then I would be giving a smartphone to a person and saying you can only use it to make calls, right? Yeah. There's so much more that you can unravel. So I think this is a behavioral modification tool, right? And by using it in people with type 2 diabetes, even those without insulin, they're able to understand their diabetes fingerprint, right? Yeah. How their body functions. That's beautiful. We saw that in the Imagine study that was discussed here. And then we're also looking at how you can incorporate this in different settings. So I think there is a room or a role for CGM usage in every person. You just got to see what you're using it for. So lots of interesting stuff. We could go on and on, can't we? We're talking about 5 days of the conference just in a few minutes. But thanks for sharing your insights with us today, Kevin. Any final words before we leave?
It's every day is a school day, I think, isn't it? I fell into diabetes quite fortuitously about 15 years ago, but it's amazing the rate of pace of change in research, in guidance. And I think, yes, we have to champion a lot of this new data and new research, new guidance, but we mustn't forget the importance of education for our generalist colleagues. Again, the CGM, it's very exciting, but my colleagues are very worried they're going to be overwhelmed with 24-hour ambulatory glucose profiles and interpreting them. So education, I think, remains pivotal for our HCP colleagues as a whole.
Absolutely. And I think final word from me would be that as we are looking at all this information, and as you said, it's overwhelming for our colleagues and for us, all this new stuff, think about our patients as well, right? It's overwhelming. Living with diabetes is quite distressful, and it's important that we don't lose sight of the individual's experience as well. The financial burden, the mental stress that accompanies diabetes, all of that has to be encompassed. So all these new medications and technology, they are great as long as they are accessible for our patients as well. But that's it from San Diego. Thanks, Kevin. Hopefully I'll see you next year.
Cheers.